Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. The patient had complex cataract surgery and ended up not only with posterior capsule rupture, but anterior capsule rupture as well, and then needed an anterior vitrectomy and was left aphakic because there was no easy way and stable way to put a lens into the posterior segment. This doctor did not want to put an anterior chamber lens, which I agree with. I always try to avoid anterior chamber lenses at all costs. They can cause a lot of problems. And so this patient was referred to me for a Yamane technique, and you're going to see how I'm able to easily, with my stepwise approach, perform this modified Yamane technique in the way I'm able to do it with a sensor lens with the delicate PMMA haptics. And again, there's been issues with the C2 Lucia lens with the haptic rotating out of the optic. And so this is really the best way, in my opinion, to deal with this situation. Just use a different lens. I've heard of people trying to kind of modify and try to do things with that lens, and that's fine and all, but it's better if you have a better technique which you can use on a different type of lens implant. So you can see this patient's aphakic. You can see some capsule remnant as well. I'm using an inked cannula tip, and I'm gonna go ahead and mark the limbus on the right side, and then using the cannula to find 180 degrees apart, I'm gonna mark the left side. Again, the Weck-Cel sponge is really very important to be able to dry the surface of the eye. It is the best tool to dry the surface of the eye when you're trying to make your marks. And this is a fixed caliper for the Yamane technique. This is from Epsilon. This is 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent. And by indenting the eye, you can see those little marks, and then I'm able to dry it off. And then using the inked cannula, I'm able to create nice and discrete marks. Do the same thing on the left side. Again, 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent, drying the surface, and then using the inked cannula to mark those indentations. This is my incision for the AC maintainer, and then my incision for the contralateral incision to externalize the leading haptic. And then these are the other incisions as well. This is the right side needle, bending it 9 millimeters from the tip, making sure the bevel is facing towards me when I have the needle in the eye, making sure there's BSS mounted with a syringe, bend about 70 to 80 degrees. This is the left side needle, bending so that the bevel is facing away from me. Again, the right side needle is facing towards me. This is a 25 gauge needle that's used to dock the leading haptic and pulling it out of the eye. The bevel is going to face towards the right for that 25 gauge needle. This is the cartridge, and I'm placing the sensor lens, making sure it's seated, making sure the optic is seated into the cartridge, pushing the wings together, making sure the optic bends backwards concavely, and the leading haptic goes straight into the barrel, and the trailing haptic comes out from the back end of the cartridge. You can see that the haptic is still inside the barrel here, and so I'm going to go ahead and use a cannula and lift and sweep that haptic over the barrel, just like that. Good. And now I can safely place the plunger in and advance the lens, twisting so that the lens is advanced. So there we go. I'm pushing some dispersive viscoelastic to coat the corneal endothelium. Again, this patient's been vitrectomized, but go ahead and fill it anyway. And this is my 20 gauge AC maintainer. Turn on infusion. This is a 25 gauge needle going through the contralateral limbal incision, going in, bevel down, turning the bevel of the injector to the left, making sure both bevels are facing each other. My assistant is advancing the lens, making sure the leading haptic is docked on the bevel of the needle. She's advancing the lens, and as it's advanced, I'm able to pull the needle out, and the leading haptic is outside of the eye. I take over, making sure the optic comes out flat, and then making sure that the trailing haptic is swept to the right. And this allows the optic to open up. And this is the other thing, I don't say this, but I should say it because it's important, but this goes without saying. You want to make sure the optic opens up fully before you try to do the Yamane technique, right? That makes sense, but you have to do that. And I'm going to go ahead and say that explicitly here, okay? I just pulled out the AC maintainer and put it back in because I wanted to make sure that the AC maintainer was not impinging on the optic there. You can see the optic is opening up nicely. I'm just waiting for the optic to open up. As the optic opens up, the haptic is going to be in a better orientation for cannulation through the 30 gauge thin wall needle. So again, as I'm waiting, I'm just making sure the optic's opening up nicely. You can see that the leading haptic is outside of the eye through the contralateral limbal incision. The trailing haptic is outside of my main incision. I'm pushing some more dispersive viscoelastic to push the optic back away from the cornea. And remember, I'm going to activate infusion now when I place the needle through the sclera. You need to have a firm eye. Here we go. I grab the incision. I'm going to place the 30 gauge thin wall needle. From that first mark, I'm going to tunnel through the sclera, making sure I'm in the sclera, tunneling 2 millimeters and then diving straight towards the nerve. And then I rotate and turning that needle into view. Very gently, I'm pushing the optic away from me with the forceps. You see some irises coming out. So now I'm going to turn off irrigation. This is very important. Iris started to come out, turn off the infusion. No big deal. Very gently, I'm placing the haptic into the incision, doing a sliding maneuver, going sideways and sliding in. You don't want to jam it in because then you'll bend the haptic. Don't do that. You saw I did a sliding towards the left maneuver and went right in. And now I'm able to align the haptic towards the needle, dock the haptic on the bevel of the needle, and it goes right in. You can see, put some BSS on the cornea to improve your view. Have your assistant just put more BSS on the cornea. Anytime there's corneal folds, that's what improves your view. I'm able to dock the haptic on the bevel of the needle, and it goes right in. All because I've externalized the leading haptic through the contralateral limbal incision. Again, such an easy way to do this. Don't make the surgery hard on you. Make it easier for you. That's the whole point. There's no reason to be a hero. You don't want to be a zero either. Go ahead and make your life easier so that you can execute the surgery easier and safer for the patient. With microforceps, I'm going to internalize the leading haptic, placing it into the angle. And then I'm, again, turning on infusion. And here we go with the left side 30 gauge thin wall needle. I'm going to hold the eye with the incision. Grabbing with the forceps, trying to make sure the eye is nice and firm, placing the needle from the first mark. You can see how I'm just grabbing and re-grabbing because I want to make sure I have a nice stable chamber. And I'm going to grab, tunnel 2 millimeters to the second mark, and then I dive down. You can see this patient's been vitrectomized and the eye is collapsing a little bit, even though I have infusion pressure on with the AC maintainer. So now my needle is in proper position, carefully grabbing the haptic with microforceps, making sure I use my left hand to rotate the syringe in such a way that I can see the bevel, docking the haptic on the bevel of the needle, and that happened very quickly. You saw that. Making sure the optic is well centered, I'm pulling the left side needle towards me. As I pull it towards me, the haptic will come out, and then grabbing it with microforceps, and then quickly cauterizing the tip. And pay attention to this. You know that I have a nice scleral support because the haptic is laying flat on the sclera. If I didn't do that, if I just went straight in and out with a perpendicular incision, the haptic would be pointing towards the sky, which is what I call the flagpole sign, which is terrible technique. You should not have the flagpole sign. If you do that, that means you have not enough scleral support, which means your optic will sag posteriorly. You can see here, beautiful flat positioning of the haptics along the scleral surface, which means I have nice scleral support, a nice scleral shelf, which means the optic is going to be in the more normal anatomic position. Right here, you'll notice there's some anterior capsule material there that the optic is getting snagged upon because I didn't actually remove that optic material there. Let's go ahead and place a tendon-Allen suture through my incision, burying the knot. You want to turn off infusion when you're trying to bury the knot, and then hydrating my incisions. But I noticed that the eye is still leaky, and that's because where I made my incision, it actually intersected with the other surgeon's temporal incision. So I had to put in another suture. This is the surgical PI using the vitrector, turning the port down. Again, the fixed cut rate is at 30. It's very low. Aspiration rate is low as well. You don't need high aspiration. You just need high vacuum for occlusion, and then you're able to cut very slowly. You get a nice discrete and peripheral PI. This is intracameral triamcinolone. I'm just filling the anterior chamber, making sure there's no vitreous in the anterior chamber, and then using the vitrector to remove that cannulage. And then I'm using the same vitrector to remove the viscoelastic in cortex mode. Pulsing some BSS into the anterior chamber, just like we do for the ICL. And I noticed that, again, it's still leaky. Again, like I said, my incision transected with the other surgeon's phaco incision, so it made a little bit of a big incision. And there's quite a bit of astigmatism with this. And the patient, you can see there's all three sutures are rather tight, and so this patient ended up with quite a bit of astigmatism right after surgery. Of course, I took the sutures out, and that improved. Go ahead and hydrate my incisions, and that'll be the end of the case. So again, this is a patient who is aphakic. You saw my standard technique, my modified Yamane technique. Again, externalize the leading haptic and makes doing the trailing haptic cannulation of the right side needle through the trailing haptic so much easier because the leading haptic's pulled out. Again, with the 25 gauge needle docking technique, it's a no grabbing technique, so it's very delicate and gentle on the haptic. You're able to essentially, by externalizing the leading haptic, the whole optic is pushed and pulled away from you, which gives you a lot more access to cannulate that right side needle with the trailing haptic. And then internalize the leading haptic into the eye, and then doing the same thing on the left side. And then you saw my technique of withdrawing the needles. I like to do them simultaneously, but really just in sequence, because you want to make sure that they don't slip out. It's been my experience that these sensor lenses with the PMA haptics, they tend to, the needle, the 30 gauge needle tends to grip the haptic a lot better than the polyvinylidene fluoride haptics of the C2 Lucia. Again, the C2 Lucia has a lot of issues going on with this rotation of the lens in the haptic. You don't have to fuss with that. You don't have to, laser the haptic optic junction or all this stuff that people are advocating. You could do that, but why would you do that? And you're putting in laser energy into the eye like that. You just worry, what is that going to do to the retinal function? But nonetheless, I'm able to bypass all of those problems by performing my modified Yamane technique using the sensor lens with the PMA haptics, externalizing the leading haptic with my 25 gauge needle docking technique, and then performing the trailing haptic first. And this patient did very, very well. So I hope this was helpful to you, and I thank you for your attention.